Okay, so good morning, friends. So today I'll be talking on 11th journal update on COVID. So the topic I'll cover is convalescent plasma. So I'm giving this presentation on 28th April 2020, as you see. So, friends, you would know that there has been a lot of noise on convalescent plasma, and there is a huge sensation created across our country on this convalescent plasma. So I have to confess I'm not a hematologist, so that's why I reviewed this articles pertaining to this a little bit late, because when I tried to look into all the literature, so I saw there's no formal presentation on this, at least I could find in YouTube or anywhere else. So I thought I will take on the responsibility to dwell into the literature of convalescent plasma to see if there is really uh, would this be a game changer, or is there really a science in this that will make a difference to the current prevailing pandemic. So I reviewed two good articles that has come on the role of convalescent plasma. So you will see as to whether there is really any juice in this whole science, whether it can make a difference. So the answer for me at the outset is uh, it has only created sensation. So I don't think there has been robust evidence at all for this convalescent plasma. If at all, there are only anecdotal reports and only case series as of now with convalescent plasma. And the science is evolving, so I wouldn't discount this completely, but the evidence for convalescent plasma, when you purely look from the publication aspect, it is way less than the prevailing literature on at least hydroxychloroquine or any other drug modalities. So anyway, so we'll just dwell into the science of this. So this is the article I reviewed. It's a very good article. I urge people to read about this because you'll get to understand the complexity of this virus when you read about this molecular the molecular variables that are involved in the pathogenesis of this disease. So this article was neutralizing antibodies against SARS-CoV-2 and other human coronavirus. So this was published by US group in April. So what this paper really deliberates upon is to look at all the antibodies they have studied against coronavirus. So friends, you know the COVID-2 is a SARS coronavirus 2. So what they, in this paper they have done is, because there are two other variants of coronavirus which has caused epidemics. So which is the SARS-1, SARS coronavirus 1, and Middle Eastern respiratory virus. So these authors have reviewed all the antibodies that are studied against this coronavirus and try to develop monoclonal antibodies which may be effective against these viruses. So this is what they have tried to look into, and trying to understand what are the antibodies produced against COVID-2, and try to see if there is any scientific plausibility in understanding these antibodies as a therapeutic option. So that is what this paper deliberates upon. And so if you look at the elements in the COVID virus, which predominantly has an antigenic effect or has a pathogenic effect, is all these elements. The spike protein, S protein, is one of the key component which leads to pathogenicity of this virus. So all these antenna-like structures you see on the virus is S protein, and the other ones which are involved is envelope protein, membrane protein, and the nucleocapsid protein. So these are the four proteins which contribute to the pathogenesis of this virus. So what is most important is spike protein, because that is something which has been used as a target to circumvent the pathogenesis of this organism. And there is non-structural proteins that have been identified. There are 1 to 66, so they have numbered. So that many non-structural proteins also are there, which contributes to various pathogenic pathways. So when you look at the spike protein, so what has been extensively studied is the spike protein. So in spike protein, there are two components, S1 and S2 subunits. So the S1, so if this is a virus, so it uses certain domains to enter into the cells. So the S1 subunit has two components, which is N-terminal domain and receptor binding domain. So it uses this, so receptor binding domain is used to adhere to the receptors, and the N-terminal domain is utilized for it to enter into the cells. So basically these are the components of the spike protein which they have studied, and they have looked at antibodies that a body develops against these proteins. So what we need to understand is S protein has two subunits, S1 and S2, and S1 predominantly acts via N-terminal domain and receptor binding domain. So for the body to counter these proteins, there are multiple antibodies that are produced. So which is beautifully picturized in this journal article. So the antibodies are monoclonal antibodies, fragment antibodies, and this is a single chain variable fragment, and nanobodies. NB is the nanobodies. So these are the antibodies which are produced to counter these spike protein. So that is how we understand what are all the elements that develop within the body to tackle these proteins. And so the antibodies against these proteins, spike protein envelope membrane, are mainly categorized into four major domains. So one is the neutralizing antibodies, the second one is monoclonal antibodies, and single chain variable fragment, and nanobodies. So these are the four main categories which counter these antigens which are present or which are expressed by the virus. Okay, so the neutralizing antibodies, they have identified ATR as one of the component which could be considered as a target for tackling this virus. And if you look at monoclonal antibodies, so they have identified these sort of an antibodies which could be effective against the SARS virus. And as I said, all these what I'm talking as antibodies which are identified against these antigens are all in SARS-CoV-1, and they're trying to extrapolate if this can be applicable to COVID-2. Okay, so we do not have clinical studies to say, to confirm. So even the authors do acknowledge there are no clinical studies to say whether these antibodies which have developed in a body against these antigens have proven to be effective, have proven to be saving the life of a patient. So there has been no clinical studies. These are all sort of an experimental studies where they have identified the pattern of these antibodies and how they may be effective in curtailing this virus. So that is where the science is. And whether these antibodies which develop against these proteins in coronavirus, whether they are effective against SARS-CoV-2, coronavirus 2, we do not know for sure. So what this paper elucidates is try to identify all the antibodies that have developed against the structural proteins which leads to the pathogenesis of the whole disease pattern. But we do not know for sure whether these antibodies are good enough to save a life of the patient in clinical studies. So that is what the authors do subscribe. And they have looked at so the neutralizing antibodies, so what we identify as one of the antibody against this antigens. So neutralizing antibodies against the receptor binding domain. So these neutralizing antibodies against this receptor binding, because the key element the authors do subscribe to is receptor binding domain, which is very important because that is the protein that is needed for the virus to adhere to the receptor on the cells to enter into the cells, and N-terminal domain is the protein that is needed for it to gain entry into the cells. So the target would be for against the receptor binding domain. So the neutralizing antibodies against this receptor binding domain, it is hypothesized that it can be used for prophylaxis and treatment. So, and authors again, the experiments have shown there are non-neutralizing antibodies which have an effect on non-receptor binding domains, which leads to antibody dependent enhancement. So that is a negative aspect. So if you have non-neutralizing antibodies working against non-receptor binding domain proteins, it can lead to detrimental effect called antibody dependent enhancement, which means there is a worsening of the disease pattern that happens because of this phenomena that is called antibody dependent enhancement. It's called ADE. So that is what authors describe. So what again we need to re-emphasize is in our effort or in our pursuit to target receptor binding domain with these neutralizing antibodies, there may be a situation where there are antibodies against this non-receptor binding domain which leads to detrimental effect, which is called as antibody dependent enhancement, because there is an enhancement of the whole antibody storm that happens which can lead to more harm. So this is what the authors. So when you read this paper, it's a beautiful paper to understand the molecular aspect of these viral effects. And so it is a around three-page article, but the essence of that article is only this much. So it basically identifies the antibodies against the key antigens. The key antigens are the spike protein, membrane protein, and nucleocapsid protein and envelope protein. And they've tried to identify all the antibodies which seem to be effective against this. Amongst that, the key component is receptor binding domain, and they found the neutralizing antibodies for that. So the hypothesis or scientific plausibility is targeting that may help in mitigating the effects of this virus. But in our pursuit to do this, there may be something called antibody dependent enhancement, which can also occur as a corollary. So that is what is the essence of this paper. So now we'll move to what is this whole science about convalescent plasma. So this whole science of convalescent plasma is playing with all these antibodies. So these so-called antibodies that develop against these antigens, you try to infuse in a patient and hope and pray that that it is helping the patients to get better. So as I said already, there is no clinical studies to prove that whatever antibodies that you infuse, whether they really change the outcome is uncertain. So that's what we will see in this review paper. So this is a good paper. So this came, this deployment of convalescent plasma for the prevention and treatment of COVID. So it was authored by Bloch et al. Came in Journal of Clinical Investigation in April 2020. Okay, so what do we understand by convalescent plasma? So it's a very simple thing. So right now I'm sure more than doctors, even the public would know what this convalescent plasma is, because there's so much of media coverage on that. So what it means is, if a person is infected with COVID-19, once he recovers, so he has recovered here, he develops antibodies against this COVID-19 virus. So because he develops antibodies, the blood is taken from him and the plasma is segregated from the blood by centrifuging, and that plasma is rich in these antibodies. So these are the antibodies which we assume will protect the patient. So these antibodies would be given to a person as a prophylaxis, so who is exposed to the COVID, to prevent him from getting the infection, or as a therapy in a patient who is already manifesting with symptoms and signs of the disease. You give it to him with a hope that these antibodies will mitigate the clinical manifestation that is present in this patient. So what is the key essence of plasma therapy is, so one needs to ascertain then there is an increased concentration of antibodies in the plasma that you extract, which means this patient who has a COVID-19, he may have recovered, but if he doesn't have a good concentration of antibodies, that plasma is not going to be useful. So the key essence to the success of plasma therapy is there should be a good concentration of antibodies within that plasma, and that they have defined what is the titers that is needed. So is this plasma or the convalescent plasma new? It is not new. It is prevailing for at least these authors in this review paper say it is present for over last 1 century. So about 100 years this convalescent plasma has been used and it is prevailing. So most of the previous literature, the older literature, has been used in prophylaxis. So it has been most effective as a prophylaxis, and it has been used in hepatitis, mumps, polio, measles, rabies. I'm sure rabies we have heard when we were studying that convalescent plasma can be the only hope, but it is very hard to get convalescent plasma for rabies. So this has predominantly in the past been used as a prophylaxis for these diseases, and for treatment they have tried in Ebola and Middle Eastern respiratory syndrome. So Middle Eastern respiratory syndrome is again caused by coronavirus. So early treatment and has shown some anecdotal reports has shown some benefit. So it has been used in Ebola. So Ebola they have found some success. So I have not dwelled into the literature of Ebola. I have mainly looked at the coronavirus to see whether there has been any positive effect with this plasma. And as I said, it is being used or in some form or the other for last 100 years is what is being referenced in this article. So how does this convalescent plasma act? So basically, because you give the plasma, so the plasma is having a lot of these antibodies. So these antibodies prevent the binding of this virus into the receptor. So you have a cell, you have a receptor here. So these antibodies prevent the binding of these virus to the receptors. So that is one action. The second effect is it has a cytotoxic. The antibodies can have a direct effect on the cells and may help in killing the cell, killing the virus rather, and the antibodies will facilitate phagocytosis of these cells and and obviously prevent its deleterious effects. So these are some of the effects it has been purported, and the most another important mechanism in which antibodies play a role is by activation of the complement system. So these are the complements. So it activates the complement system and mitigate the deleterious effect of this virus. So there are four mechanisms. One is to prevent virus binding to the receptor, cytotoxic effect, and enhance the phagocytosis and activating of the complement system. So these are the four mechanisms in which we assume that this antibody should help patient recover from the illness. So now let's look into what are the clinical studies. So the use of convalescent plasma against coronavirus. So we look into the evidence whether they have used and what has been the effect. So this is one study which is this is come from China where they have used in SARS patients in 2003. I think this is from Hong Kong because SARS happened in Hong Kong. So it was done in 2003. This is the largest case series one can find on the use of convalescent. It's a case series. So again, I have to say there's absolutely no randomized controlled trial until now, at least from the literature what I have researched. There's no randomized controlled trial with convalescent plasma to say that this has been superior to standard therapy. That is one. So this is only case series in 80 patients where they're given convalescent plasma within 14 days. And what they found is there was reduction in the viral load and there was improvement in clinical outcome. So I will show you details of that study. And 2012 they've used in Middle Eastern respiratory syndrome and COVID-19. So this is from the Chinese data. So there are only two studies from China where convalescent plasma has been used in COVID-19. So this is one study where they've used in 10 patients in COVID-19, and the titers, the IgG titers, what they looked at as a criteria to infuse should have been more than 1 is to 640. So this was the reference for the Chinese study. It came on 16th March 2020. So titers had to be more than 1 is to 640 for that plasma to be suitable to be infused in COVID-19 patient. So the Chinese authors reported there was no serious adverse events and they found improvement in the symptoms, fever, cough and short of breath within 1 to 3 days. There was radiological improvement and viral clearance also happened. So it is a case series. It is not a control trial. There is no control arm. Case series in only 10 patients where improvement of symptoms has been shown, but there was no clear mention on the mortality and there was no detailing about how sick the patients were. So we do not know whether they were critically unwell or whether they were mild or moderate. So that is where the science of usage of convalescent plasma from China has come. So this is another Chinese study. Again, as you see, it's a case series of COVID-19 where they have used in 5 patients where they have taken IgG titers more than 1 is to 1000. So which means you need to have a titers above 1000, 1 is to 1000 for it to be effective. At least if you have to subscribe to the Chinese, at least 1 is to 640 or 650. It should be more than that titers for the plasma to be effective. So we do not know whether the sensational case that has been reported in India, whether this sort of a titers was looked into, and we do not know whether it is only anecdotal one case and we cannot subscribe the whole science about its utility on a national scale based on that one anecdotal report and the scientific literature you see, because the scientific evidence is extremely sparse in COVID across the world, and we are talking about case series which is the least of the evidence, and we are sort of creating a national sensation about it. So this is where our scientific spirit should prevail to ascertain whether this is really of much use, isn't it? So this was a case series again which came in JAMA 2020, again by Chinese group in 5 patients. So what they showed, it reduced the virus and it improved PaO2 by FiO2 and it helped in mechanical ventilation weaning. So I would say this data is as good as the data that has come from hyperbaric chamber, because hyperbaric chamber also they used in 5 patients and they showed some benefit, but that doesn't mean that we put hyperbaric chambers everywhere in every hospital for COVID patients. So this is where I have a problem, because you have 5 patients, 10 patients, one case series, and 5 patient, one case series, and we are subscribing to this science on a national scale. for a scientific people like us, we should be worried because this data is as good as hyperbaric uh, literature that came out in 5 patients, and they showed a same benefit even in hyperbaric chamber patients. So this is the details of that Hong Kong study where they used in SARS patient. And this is the largest study. If you want the largest study in convalescent plasma, it's 80 patients on this Hong Kong paper that came used in SARS patients. And as you see, the clinical response is around 41.3%. They had good clinical outcome, and they say there is no adverse events and improved outcome with early administration. So as you see, this is a retrospective chart review, and 41% is the response rate in SARS patients. And here again, we do not know what is the severity of the disease. So again, they say early administration. So we assume that these patients were not very sick and they've used this, and they say there was a response rate of 41, which is again not very high response rate. It is only a case series, so we cannot make much out of it. So then, if you dwell more into other uh, reported benefit of convalescent plasma, this study is come in 2005 again in SARS-1. So this has been used in China. So they've used 500 ml. So the titers they've looked is more than 640, 1 is to 640. And again, you see it's uncontrolled case series of 3 severely ill patients, and they found improvement in clinical status of all 3 patients. Again, it's a case series, no control arm. So they have taken titers of more than 640, and they found improvement in 3 ill patients. So again, this is another paper which again came from Hong Kong group, where they have given 200 ml of convalescent plasma, and again here they say improvement in clinical status, and there was no adverse events. So this paper was a letter to editor which came from China. So here they are given 2 units of 250 ml of plasma, and again they say there is improvement in clinical status. So if you see, what we are subscribing to as a national sensation is based on case report and case series, the largest being 80 patients, and we do not know how sick was the patient, and this was all in SARS-1. If you look at COVID-19, we are creating a national sensation with 2 papers in 10 patients, one case series from China, and 5 patients case series, and showing some benefit. So as of now, so we should temper our enthusiasm in subscribing to this as a magical tool in saving lives. So that would be my subscription after having gone through the whole literature. So this came from Korean study, which is in Middle Eastern respiratory syndrome. See here, this is an interesting paper where they gave transfusion of convalescent plasma to 3 patients. They are not specified volume, but here they say it's an uncertain benefit. All the 3 patients survived. So that was the conclusions the authors made. And the dilutions they took was more than 1 is to 80 was the dilution they took. So this is all you have with regards to usage of around 5 to 6 studies you have in coronavirus, and 2 Chinese study in COVID-2 as a case series, one in 10 patients, one in 5 patients. So based on this, to subscribe to this science as something which is going to be a game changer is superfluous. So as a scientific people, we should not be overwhelmed with this sort of a science. So definitely we should do more studies. So with scientific spirit, trials has to be conducted, and not create a media sensation on this, because I don't think this is a tool which can make a tremendous difference to our COVID patients. So that's about the evidence. So let's look into, see, the authors in this review article do talk about the workflow as to how convalescent plasma has to be looked into. So again, the workflow is you have to uh, identify a patient who has recovered from COVID-19, and it should be more than 14 days after resolution of symptoms that he will become eligible for ascertaining whether he can be a plasma donor. So 14 days should have been lapsed after he is fully recovered from the COVID-19, and resolution of symptoms should have happened, and there should be a 14 days gap. So after 14 days, he has to be examined and screened whether he is eligible for plasma. So pre-donation screening, so you have to again examine him, make sure he is afebrile, and nasopharyngeal swabs again has to be taken, and confirm that he is COVID negative again, because you would have done test before, but 14 days after he's come negative, he needs to be screened, again tested if COVID is negative, and you have to do RT-PCR and look that he is COVID negative, and then you have to do antibody titers. Using ELISA, you need to do antibody titers, and the antibody titers the author suggested should be more than 320, because as you see the Chinese have used 1 in 640 in one study in 10 patients, and 1 in 1000 they have used. So here in the algorithms, as a part of the US trial, because US is conducting 5 trials with convalescent plasma, so they have taken optimal titer of more than 320 to be eligible as a plasma donor. And then you would send him to a blood collection center. 400 to 450 to 600 ml of plasma is collected. 400 to 650 ml. So basically you draw the blood, centrifuge, segregate the plasma. 450 to 600 ml plasma is taken, and then as soon as it is taken, it needs to be frozen and saved. And after that, they have to be screened for the plasma has to be screened for any routine serology and other antibody. For females, it is advocated HLA screening has to be done for female donors. And after that, ABO compatibility has to be done, and then transfusion to a suitable patient has to be decided. And whilst transfusion is being done, these things have to be kept in mind. The risk of trolley, so consent has to be taken. So this is a standard procedure that before administrating of plasma, risk has to be explained to the patient, consent has to be obtained, and then the necessary proceedings have to be done. So, so 400 to 800 plasma is collected. So basically you take the blood, you centrifuge, and 400 to 800 plasma is meant to be collected. So 400 to 800 plasma that is collected yields 2 to 4 units of convalescent plasma, and this has to be frozen within 24 hours and stored. So the dosage that is recommended is 200 ml of convalescent plasma with titers more than 320. So that we have understood. And the key element is the authors do suggest that the antibodies, the duration of action of the antibodies can be up to weeks to months. So the antibodies in the titers more than 320, its effect would last for weeks to months in convalescent plasma. And for the SARS, the SARS, when I say SARS, it's the SARS-1 coronavirus. They use 5 ml per kg. So if you are having a 60 kg gentleman, so you would use 300 ml. And the titers they used for SARS-1 was more than 1 is to 160 for the SARS-1. So that is about the recommendation. So you need to have titers more than 1 is to 320, and 200 ml has to be administered. So when you look at the literature, most of the literature have given one dose, 200 ml one dose. But in some cases where there has not been a clinical improvement, after 12 hours they are given a second dose. But generally most of those trials we saw, they are given 1 unit of convalescent plasma. So US is embarking on doing 5 trials based on this algorithms, on this understanding, on this science. So one is post-exposure prophylaxis. So healthcare personnel who have been exposed to a COVID-19 without protective gear. So for them, post-exposure prophylaxis with convalescent plasma and seeing whether they could curtail the symptoms is one trial. And they are doing one trial in mild disease to look at resolution of symptoms and prevention of hypoxemia and progression of disease. And the third trial they are doing in moderately ill patients to see whether they could prevent progression to critical illness. And the fourth study they are doing in severely ill patients who are mechanically ventilated, whether it can be life saving. So I have to say, if you look at all the studies, the 2 Chinese study and those all the previous SARS studies or Middle Eastern respiratory, there has been no report of having used it in a severely ill on a mechanical ventilated where it has saved lives. So it has been used in moderate to mild to moderate or maybe in a severe, but not on a patient's on ventilator where it has changed lives. So again here, if you look at the national media channels with all senior clinicians talking, for me, what it beats me is they are proposing this drug for severely ill patients who are on a ventilator. So we do not know whether that is a right approach, because you use this plasma in someone who is on a ventilator who may be unwell, because there is no evidence until now which says that it has saved lives in that situation. So it still remains experimental, and proposing this as a magical tool in that situation, we aren't entirely sure from the scientific, purely from scientific purview, purely from the prevailing evidence, whether it's going to help at all in ventilated patients, because there's no evidence at all where they have used in ventilated patients and they've found, and unless the whole India wants to subscribe to that national sensation one hospital has created somewhere from North India. So I think this is illogical for me at this stage to say that we use this in ventilated and hope that it will save lives miraculously. And the fifth study they're proposing is to look at the safety and pharmacokinetics in pediatric patients. So these are the five trials US has proposed, and it is embarking on doing these five trials in this five subgroup of patients. So maybe we should wait for these trials to see whether this really creates a magical response. But as far as the evidence goes, as we stand now, I don't think there's any evidence at all that it is a game changer and it has saved lives. And if you look at the historical data, it has only been used more effectively as a prophylaxis, where to prevent the onset of the disease. I think that is where we all understand antibodies have a role in preventing the severity of the disease. So once the disease is full blown, there are too many other variables which are making patients sick, because once patient is on a ventilator like this, you would understand it is not about antibodies, it is about the whole organ dysfunction that has set in because of cytokine storm and all the interleukins and everything. And just infusing 200 ml of antibodies, whether it can curtail the storm that is prevailing, I think that is left to one's wildest imagination. So for me, after having dwelled into this whole science, it appears that the sensation it has created, it is not warranted for this plasma, because convalescent plasma at best remains experimental, and the evidence is much weaker than all the drug trials that has come out so far. I would say the evidence for HCQ, if I had to rate around 7 out of 10, I think the evidence for this is less than 1 out of 10, I would say. So that would be my subscription to this. So some of the drug trials have a better trials, better control trials have been done, because as you see, there is no control trial at all for convalescent plasma. It is only based on some case series that we are subscribing to this. So what are the potential risk of convalescent plasma? Because we know when you administer plasma in a ventilated patient, there is a risk for TRALI, transfusion related acute lung injury, transfusion associated cardiac overload, and there is a remote possibility of introducing SARS-CoV-2 infection to an already infected. Albeit, the authors say the SARS-CoV presence in blood is only 1%. So it is not found in blood. Mainly, it is present in respiratory secretions and feces, and the presence of COVID-19 in the blood is very low. 1% is what is reported. And this, I said, antibody dependent enhancement is another side effect. So you infuse this 200 ml of antibodies, if it can work against by causing antibody dependent enhancement, which leads to worsening of the clinical symptoms. So that is also something which we need to keep in back of mind. And authors in this paper, I think for all the listeners who may be interested in statistics, read this. There is a one-page write-up on this risk-benefit analysis, where they have done statistical modeling. They have done a scholastic statistical modeling to see what is the risk-benefit analysis based on the projections from the numbers. So what they have suggested is, if this convalescent plasma, this is an assumption, this is hypothetical assumptions they have made based on statistical modeling. They have used scholastic modeling, and see whether it will uh, it will weigh with risk benefit whether it proves to be effective. So what they have said is, if it is 25% efficacy, if this convalescent plasma is 25% effective, this x-axis shows the number of lives saved. Okay, so it has some ability to save lives, and if it is 50% efficacy, you see this slowly moving to the right, so it tends to save more lives. And if it is 75% efficacy, then it may be helpful in saving lives in this elderly age group, 50 to 74 years. So this triangle is 50 to 75, so it may be helpful in saving lives in elderly patients if used. So this is only a statistical modeling. So this is an assumption. If it is 75% fully effective, this convalescent plasma, it may be helpful in saving lives in bigger numbers and in elderly people. So this is what the authors subscribe. So I would end my talk again. A recent study showed that all recent studies are false. So I think this is where we are at. So right now, for all the listeners, I think there's no magical drug at this point of time to COVID. So whatever we have understood from all the 11 updates that I have been narrating is there's no absolute magical tool against the COVID. So the science is evolving. There are about 15 drugs tried. Convalescent plasma is one of them. They all remain experimental. If at all anything that has tried in bigger numbers in more trials has been hydroxychloroquine, and even molecular, uh, the way the mechanism of action in a multimodal way, it seems to still hold some value at this point of time, although clinical trials have hit a equipoise on that. So for me, the convalescent plasma at this point of time is very experimental. I don't think any of us need to be overwhelmed with this science, because there's not much data at all subscribing to its absolute benefit for these COVID patients. So obviously we need to do trials. ICMR is doing trials, which is a good thing. So we'll wait for the results of the trial, and I need to see in what group of patients we would be using this convalescent plasma, because definitely it appears that this may have some role in prevention and maybe in mild to moderate, but in severely ill ventilated patients, I think it is too premature for us to make logical conclusions that it's going to be life-saving, because I've seen some senior doctors saying that this drug, this convalescent plasma, is reserved for sick ventilated patients. I believe that is not the right way to approach, because in these patients it may not be of any help, because there's absolutely no data. There's absolutely no data, and we can't base our whole science on one sort of anecdotal report that came from some hospital somewhere from north. I think we cannot subscribe to that. So that would be my subscription to this whole science. So thank you very much. You can visit my website www.drpradeeprangappa.com to rehear to this lecture to gain clarity. Thank you.